Well, thank you very much for inviting me. It's always a pleasure to come and talk about the missing third of our life, which we very often forget about. I'm very sorry about my voice. I have a bit of a cold, but I'm hoping it will last the 40 minutes. So I wanted just to explore a little bit today the assessment and treatment of organic sleep disorders. And there are a very wide range of sleep disorders, and I'm not going to cover all of them. But I thought that these 5 disorders were fairly representative. They would give you a good overview of how one goes about assessing disorders and what the treatment options are. So the one sleep disorder most people are fairly familiar with is obstructive sleep apnea, where as you fall asleep, the muscles that hold your throat open relax, and in some people those muscles then relax too much, or the throat has a lot of external pressure because of adipose tissue or fluid accumulation. The throat collapses, the person chokes, that wakes them up, and then they fall asleep, snore, choke, wake up, and so on. And it's something that you'll also see quite commonly following acquired brain injury for various reasons. So what are some of the warning signs you would look for if you sort of concerned someone might have sleep apnea? What are the things that would make you think, this should be checked? Yeah, are they sleepy is number one, yeah. And what do the partners complain about? Snoring. So your sleep, they're your sleepy snorers, basically. And sleepiness is often their presenting complaint. They come to the clinic and they say, I'm falling asleep in the cinema, I'm falling asleep on the bus, I'm falling asleep standing up in the bank queue. And we sometimes want to measure that sleep, get some sort of figure to it. And what's very commonly used in sleep medicine is the Epworth Sleepiness Scale. And I'll show that to you in a moment. And there's a bit of debate as to where the cutoff is between normal sleepiness and excessive sleepiness, but generally it's above 10 or 11. They snore, but can you have sleep apnea without snoring? Yeah. And who in particular is likely to have sleep apnea without any audible snoring? Sorry? Children might well, yeah. Children will often have a kind of very heavy breathing, and part of the reason is children are often quite good at opening their airway by rolling onto their stomachs and hyperextending their necks. But the other group of patients is women. There are a certain proportion of women will have quite profound sleep apnea without there being any notable snoring. What are the other things you might look out for? Sorry? Weight. So they're overweight, yeah. The majority of sleep apnea patients are overweight, but by no means all. You can get people with sleep apnea who are absolute beanpoles. And this is often a very frustrating thing. In the area of London where I work, the local clinical commissioning group will not refer patients with a clinical suspicion of sleep apnea if their BMI is below 30, which is just ridiculous. Other things to look out for: people with hypertension and diabetes, cardiac arrhythmias, particularly if they have repeated cardioversions, for example, and they sort of have recurrence of atrial fibrillation, overweight, thick neck, and then a receding jaw, your Queen Victoria jaw, for example. Because the lower jaw, if it's set back a little bit, it pushes on the throat and therefore reduces the space in the airway. A large tongue, and essentially any sort of facial morphology abnormality, you want to just think about obstructive sleep apnea. This is the Epworth Sleepiness Scale, and I'm sorry it hasn't come out very big, so I'll just run through it with you very quickly. Essentially, you're giving the person 8 scenarios, and you say to them, how likely are you to fall asleep in each of these scenarios? And fall asleep could be gone, or it could be that momentary nodding off. And they say no chance, slight chance, medium chance, or high chance. Now, this scale is slightly idiosyncratic. It was developed in Australia, where it assumes that everybody drives, which clearly in the UK is not the case. And so sometimes what you have to do is say to the person, well, if you haven't been in that scenario, imagine that you were how likely would you be to fall asleep? And the scenarios are sitting and reading, watching TV, sitting inactive in a public place, such as a theatre, a waiting room, a bus, as a passenger in a car for an hour without a break, lying down to rest in the afternoon, sitting and talking to someone, sitting quietly after lunch without alcohol, and in a car while stopped for a few minutes in traffic, and here it's assuming that they're the driver. Now, the reason it's a slightly odd scale is clearly if you've got a high chance of falling asleep when you are lying down to rest in the afternoon, you would score 3 points. If you have a high chance of falling asleep while you're in conversation with someone, you also score 3 points, and clearly these are qualitatively very different things. But this is such a widely used scale that basically if you're referring someone to a sleep clinic and you refer them with their Epworth, the sleep clinic knows immediately whether that person is really sleepy or not. How do we investigate for it? It used to be a very expensive proposition. You used to have to put people in a lab overnight. We very rarely do that now. Pulse oximetry is often a good screening test. This is a very straightforward little device. It's measuring the oxygen saturation and the heart rate through the night. It's cheap, it's easy to perform. It has the advantage that it can be done in a home or on any ward. So you don't have to go into the sleep clinic to do it. You can do it on a general surgical ward, a medical ward, a rehab ward, a psychiatric ward. Got good specificity. If you look at a pulse oximetry and it says you've got sleep apnea, you've got sleep apnea. It doesn't have great sensitivity though, and particularly for slim patients. And the reason is, it doesn't record the choking episodes, it records drops in oxygen. And if you've got a slim patient who's generally ventilating well, they will usually wake up before their oxygen level starts to drop. So it will significantly underestimate the severity of their sleep apnea. So generally our policy at Guy's is if a patient has a BMI below 25, they come in for an inpatient sleep study. Over 25, we'll screen them generally first with the oximetry. But I think a good rule of thumb is this, is that if you have a patient who has got a strong clinical suspicion of sleep apnea and the oximetry is negative, you should go on and do another sleep study. You should trust your history more than the oximeter. So this is, I'm sorry this has come out so small, this is an oximetry of someone with severe obstructive sleep apnea. That's the oxygen saturation, that's the heart rate, and what you can see is that they're just repeated drops all the way through the night, these repeated desaturations. And of course, you can see how stressful it is for the body by looking at the heart rate variability. There is an art, though, to interpreting these oximetries. There's a temptation just to look at the figure. You know, it'll print out a sheet saying the 4% oxygen desaturation index is 23 per hour or whatever. And the temptation is to say, okay, well, that's my answer. But actually, it's really important to look at the tracing because you get some very important clues from that. And here's an alternative pulse oximetry. So here, the person's got absolutely normal saturations. That's what it should look like through the night. But you're getting these very discrete episodes of significant desaturation. So clearly these sort of circumscribed episodes of apnea. Anyone want to hazard a guess as to what's going on? Lying on the back. So that's number one. Could this be postural? And you do get people who have purely position-related sleep apnea. They will only have apneas, for example, on their back, and they breathe beautifully on their side. So that's certainly one possibility. What else?
Could it be the stages of the circadian rhythm, like waking up, going back to sleep, deep sleep?
Yeah, so you've sort of alluded to two possibilities there. The one is the person simply awake between those episodes? And very often you see insomnia with sleep apnea, and when you're recording oximetry, you don't know for sure whether the person's awake or asleep, and could some of this have been done while they're awake? And then the third one is, what stage of sleep are they in? Because in rapid eye movement sleep, as we'll talk about in a moment, your muscles should be completely paralyzed. You have a complete loss of muscle tone during REM sleep. It's what prevents us from acting out our dreams. What that means is that the accessory muscles of breathing, your intercostal muscles, and the muscles which hold your tongue forward and hold your throat open are also paralyzed. And so you will get some people who will only have apneas or will have a significant exacerbation of their apneas in REM. And that's the case for this patient here. This is their hypnogram. These bars here are their episodes of REM sleep, and you can see they correspond beautifully with the desaturations. Now, once you're experienced at looking at the oximetry, you can usually pick out whether this is postural, REM-related, or whether they're awake. But it can be incredibly useful to actually get 2 nights' worth of data. Because if it's to do with their position, or if it's to do with wakefulness during the night, you would expect a different pattern on the 2 nights. Whereas if it's REM-related, you'll tend to see that you're getting those desaturations at much the same points on both nights. So 2 nights data often tells you a lot more about what's going on than 1. The next level up are the respiratory studies, and here essentially you're using oximetry, but also some way of measuring nasal flow, the airflow through the nose, and then abdominal and chest bands, which measure the respiratory movements. And here, what we were looking for is when a person stops breathing, do they also stop trying to breathe? And if that's the case, then in fact they've got a central apnea. And of course, particularly if you're working in patients who've got brain injury, there may be a much higher rate of central apneas. And you see no flow, but also no effort. They're not trying to breathe. Whereas with an obstructive apnea, the flow stops, but the chest and the abdomen carry on moving, trying to suck air in. Much more sensitive than oximetry, but obviously it takes a little bit more time. It can be done at home. Quite often now people will come and get wired up and go home with them. In the big labs in the States, they get dozens of people coming in each night. They wire them up and send them off to a local hotel. And they just come and drop the equipment off in the morning. But of course, this makes it much more prone to technical problems. What you can do if you're doing it as an inpatient, which is useful, is to be able to see what position the patient's in. Is it a supine-related sleep apnea? And if you find barn door sleep apnea in the first hour or 2 of the study, you can actually titrate them onto CPAP on the night. So it's a much quicker way of getting on top of the problem. Polysomnography is the gold standard. So here we're using EEG, EMG, EOG, usually an ECG, and the respiratory array that I've just mentioned as well. And what's useful here is that you will have some patients, as I say, who may not have particularly severe sleep apnea, but that each time they have an apnea, it significantly disrupts their sleep. And with those patients, you might want to treat them more aggressively than you would if you only had a respiratory study, because you can see actually what it's doing to their sleep. Allows you to look at the severity in the different stages of sleep, and of course you can screen for other sleep disorders simultaneously. So that's the CPAP. That's the standard one that we generally start with in our lab. But really important treatment for most patients is weight loss. And if people lose enough weight, they have the potential to be cured. Now, you can see that that's probably not the sexiest thing to sleep with every night of your life. So, there's a good motivation to lose weight. It's not a guarantee because, as I say, you get skinny people with sleep apnea, but they can certainly significantly improve and possibly cure their sleep apnea with weight loss. What about if they're only having apneas in the supine position? What's the traditional remedy for that? Sorry? To sleep on the side. And how do we do that? Absolutely. It sounds ridiculously simple, but the tennis ball on the back of the pajamas can work remarkably well. Or else getting the partner to wedge pillows behind their back when they go to sleep at night so that they physically cannot roll over. It sounds too simple to be true, but actually in a lot of patients will work. If it's mild to moderate sleep apnea, we're increasingly using mandibular advancement splints, and these are like jaw guards that you put in your mouth at night, but they pull your lower jaw forward like this. So you can see I can snore, but if I do this, can't snore anymore. Holds the airway open. That'll only work for mild to moderate. Moderate to severe, it's got to be the CPAP. Unless I think in my years I've had one patient who said, I hate CPAP, I hate having sleep apnea, I want a tracheostomy. That's the only other alternative. Moving on to restless legs and periodic limb movements. Now, these are separate disorders, but actually I think they very often occur together, and also they probably have the same underlying pathology. So I just want to tell you a bit about them. Restless legs is the patient has a subjective sense of discomfort, usually in their legs, but it can be anywhere in their body, which is worse at night and is temporarily relieved by movement. And as a result, when they go to bed and they get this awful discomfort, which they usually can't quite describe, they'll use lots of words like it sort of feels a bit kind of almost, they can't quite put their finger on what it feels like. And they just have to move their legs around, kick their legs out, get up and walk around in order to get comfortable, which of course makes it very difficult for them to sleep. Periodic limb movements occur when the patient is asleep. And here what's happening is that there are these unconscious leg twitches, which the patient's not trying to move their leg, it's an automatic thing, but it then potentially disrupts their sleep. And the reason I say it may disrupt sleep is you can see people who've got very profound periodic limb movements who report feeling absolutely fine during the day. And others can have quite mild periodic limb movements and complain about feeling absolutely shattered and feel that their sleep is very poor quality. So how do we assess for them? With restless legs, really and truly, it's a clinical diagnosis. The diagnosis is made purely on history. Despite this, and despite the fact that it can be unbelievably distressing to patients, what strikes me is how rarely patients come into the clinic and say, I have this awful restlessness in my legs at night. They will very rarely volunteer it. And you have to ask the question. And when you ask, they go, oh my gosh, yes, that's exactly what happens. It's terrible. I've had it for 20 years and it's awful. And it's just striking. I guess that they perhaps don't see it as being a medical issue or something that you would tell a professional. But once you ask about it, there's this palpable relief that somebody's actually going to treat it. Polysomnograms generally don't add anything. What you see is the person has restless legs before they go to sleep. You already knew that. You want to screen for peripheral neuropathies, so do a general neuro exam. And then look for any underlying biochemical causes. So the blood tests that we do are ferritin, folate, vitamin B12, U and D, and glucose. It's extremely common in patients with kidney dysfunction, patients on dialysis. About 15% of diabetics have it. And low iron is probably the most common driver. And it's one of the reasons why you probably see quite a lot of it in pregnancy. Periodic limb movements, on the other hand, are practically impossible to pick up on history. They're the hardest sleep disorder to screen for. So here you really need a polysomnogram. You need to actually watch someone sleep, see if their legs are moving, and see if that's disrupting their sleep. But aside from that, the workup's the same. You screen for neuropathy and do the same blood tests. Treatment. If the ferritin is below 50 micrograms per liter, we suggest giving iron. And the reason is that iron is a cofactor in the production of dopamine, and lack of dopamine in certain areas of the brain seems to be what drives periodic limb movements and restless legs. Now, you probably know in your lab what's the lower limit for ferritin? Does anyone know? For most, it's 13 to 19 micrograms per liter. So the problem here is that if you say to the GP, can you do a ferritin level, and the ferritin comes back as 21, they'll say, oh, it's fine. But actually, when you've got restless legs or periodic limb movements, we would give iron until that ferritin is above 50. And what we think is going on is that some people are just not as good at transporting the iron across the blood-brain barrier and therefore need a higher load in the blood in order to force it across. A few patients will report a worsening of restless legs with exercise, but the vast majority will find that it improves it. Only on the night that you exercise. It's not a sort of long-term thing, but exercise during the day seems to improve symptoms at night. And lots of patients, particularly younger patients who are keen to avoid medication, will be very keen on behavioral approaches such as this. There's also evidence that using cognitive behavior therapy for insomnia improves sleep in patients with periodic limb movements. And certainly our experience has been that lots of restless leg patients find their symptoms are less severe when they've done the CBT for insomnia. So although this is a very organic disorder, you can use psychological and behavioral interventions quite effectively in some patients to treat it. If that's not working, these are your licensed drugs. The dopaminergic drugs, these are the drugs used generally for Parkinson's disease. We use them at much lower doses when we're treating restless legs or periodic limb movements. I personally favor ropinirole simply because if you look in the BNF, they lay out very clearly what the titration regime for ropinirole is when you've got restless legs. And you can get quite small denominations of the medication, so you can do very gradual titrations. And that makes it very easy for the GP to do it without the patient having to come back to clinic every time they need a dose increase. However, although these are not licensed, pregabalin and gabapentin, there's good trial data showing their efficacy in these disorders. And of course, because lots of patients will have comorbid neuropathic pain or comorbid anxiety, sometimes we'll go straight to those. If that's not working, this is the aspirin of sleep medicine. We throw it at pretty much everything, and it works for most things, and that's clonazepam. And if we're really battling opiates, and some patients even will be on methadone if we can't control it any other way. This is probably the most relevant for today, I guess, with the theme being brain and behavior. These are behaviors during the night, primarily, parasomnias. And we divide them into two types, the non-REM and the REM, or you can also call them the slow-wave sleep parasomnias, because the non-REM parasomnias almost exclusively occur from slow-wave sleep, which is your deep sleep. So sleepwalking, sleep sex, sleep eating, night terrors, and confusional arousals. And everyone here has probably had a few confusional arousals in your day. You've just fallen asleep and your bleeper goes off or the phone rings, and you wake up and you don't know where on earth you are, and you are stumbling all over the place and disorientated. And your friend says, I had this weird conversation with you last night, were you drunk? And you say, I don't remember having a conversation with you last night. That's a confusional arousal. On the REM side, there's REM behavior disorder, which is very common in patients with Parkinson's disease, Lewy body dementia, and is very often one of the first signs of those illnesses. The other parasomnia, which really is very rarely asked about, but actually has a huge impact on people's quality of life, is nightmares. And in fact, of all the sleep disorders, the one that has the strongest predictive value for suicide is nightmares. So we should always be asking about them. How do we assess for them? Once again, this is a diagnosis almost always made on history. With non-REM parasomnias, they will typically occur in the first half or even the first third of the night, because that's where you get most of your slow-wave sleep. There's very rarely any dream recall. You don't dream very much during slow-wave sleep. They very often will have a history going back to childhood, and they may evolve. So they may have sleepwalked as a child and gone on to sleep eating or night terrors as an adult, for example. And quite often they'll have them as a child, they'll resolve, and then they seem to re-emerge when they're adults. And they tend to be very complex behaviors. They will often get out of bed, move around, manipulate objects, open doors, turn on cookers, etc. The REM parasomnia as well, look, they will happen in the second half of the night because that's when you have most of your REM sleep. Dream recall is very common, and obviously that's the problem when you've got nightmares. REM behavior disorder is something that occurs in later life. It's not something you would expect to see in childhood. And the behaviors are quite disorganized. here in REM behavior disorder, what's happening is that you have that normal atonia that you should have in REM sleep, that normal paralysis doesn't kick in. And so the person acts out their dreams. But they don't get up out of bed and act out the dream. They're thrashing around in the bed in quite a sort of wild and kind of disorganized way. And so they very rarely get out of bed when they're having a REM parasomnia. The polysomnogram is useful. Certainly, the one problem, of course, is, and patients always say this, what if I don't sleepwalk on the night I have my sleep study? And inevitably, 95% of them don't. But actually, we don't need them to. The diagnosis has been made on history already, and what we're really doing here is looking for any exacerbating factors. What we do quite often see in patients with slow-wave sleep parasomnias is very brief confusional arousals. They'll spontaneously wake up from slow-wave sleep, look around, head back on the pillow, and straight back into slow-wave sleep. So we'll see that quite frequently. With REM behavior disorder, we don't need an episode to happen on the night to make the diagnosis. If there's a clinical history of fighting in the sleep, acting out of dreams, and they come into the lab, what we'll see on their EMG is that when they go into REM sleep, they maintain muscle tone, and they shouldn't. When you go into REM sleep, your muscle tone should drop down to absolute zero. But in REM behavior disorder, you see continued muscle tone in REM sleep, and that gives you a very clear diagnosis, even if there's no behavior observed. But as I say, really the main reason for doing it is to see are there any exacerbating factors like obstructive sleep apnea or periodic limb movements, which might be disrupting the sleep and therefore precipitating these parasomnias. Treatments, the non-REM parasomnias, there's practically no evidence-based treatment here. There have been a few case series, a few small trials, but very, very little evidence actually. And so it's very much based on our clinical experience. We think that the three big drivers of slow-wave sleep parasomnias are sleep deprivation, stress, and alcohol. So good sleep hygiene, avoiding alcohol, avoiding too much caffeine, making sure you're getting adequate sleep. If stress is an issue, doing stress management, possibly CBT for anxiety can be useful. People always raise their eyebrows when that one comes up, but actually there have been two quite large open label trials showing efficacy for hypnotherapy. Antidepressants. Now, some people will have an exacerbation of their parasomnias on antidepressants, but some people experience significant improvement. And here we're talking about SSRIs, clomipramine are the ones that we tend to use most frequently. And of course, the aspirin of sleep medicine, again, really does work. And quite often what we'll do is we'll give people a bit of clonazepam as a rescue remedy. So if you're going to a festival and you're sleeping in a tent and you really don't want to have a night terror in the middle of Glastonbury, we give them clonazepam for that. But there are some people who give it long term, and interestingly, tolerance and depends don't seem to be big issues when it's used for this indication. Your REM parasomnias. So for REM behavior disorder, my first line now is melatonin. Circadian 2 milligrams nocte is remarkably effective, and it reestablishes the REM atonia. So it actually sort of treats it at source. Once again, no big surprise, clonazepam works, but clonazepam doesn't reestablish the REM atonia. So they maintain muscle tone, but you just get less behaviors being enacted. Nightmares, there's obviously lots of work being done on psychological treatments, such as imagery rehearsal therapy. The strongest evidence base, though, is for prazosin. Has anyone used this? Works very well, doesn't it? It's quite remarkable. This is an alpha-blocking antihypertensive. And generally speaking, you give it, you titrate the dose up, and nothing happens, and suddenly you hit the right dose, and the nightmares just abate dramatically. And then, actually, the one that I use most commonly is trazodone. So there's been one relatively small but encouraging trial with trazodone, but certainly my clinical experience has been that people experience significant improvement in nightmares and their insomnia with the trazodone. So you can kill two birds with one stone. And finally, I just want to talk a bit about circadian rhythm disorders. This is one of my favorite topics, really, and I just need to set the scene for you a little bit. So each of you, in every cell in your body, you have a clock. You have approximately a 24-hour cycle in all of your cells. And these need to be kept in check. The cells need to be coordinated, so you have a master clock, which is located here in the suprachiasmatic nucleus in your brain. Now, your suprachiasmatic nucleus is generally active during the day and quiescent at night. And if you chop it out and put it in a petri dish, it'll continue having that cycle, active for about 12 hours and quiescent for about 12 hours. Now, what your suprachiasmatic nucleus does is it inhibits the pineal gland and therefore inhibits the secretion of melatonin, which is made in the pineal gland. So when your SCN is active during the day, your melatonin levels are low or completely absent. When you get to evening and your suprachiasmatic nucleus starts to wind down and that inhibition gets removed, your pineal gland can start to secrete the melatonin. And melatonin is an unusual hormone in that it actually further inhibits the suprachiasmatic nucleus, so it turns off its own inhibitor and therefore increases its own secretion. So there's a positive feedback cycle. And so the rise in melatonin tends to be very steep. And melatonin is really the means by which your brain communicates with the rest of your body. It is now nighttime. We should be asleep and doing all the nighttime bodily functions. Now, the problem is that this system doesn't run at exactly 24 hours. For most people, it runs a little bit longer than that, about 24 and a half hours. And so, in order for it not to drift out of sync with the rest of the world, it needs to be synchronized somehow with outside time. And the way that we do that is with light. So in the ganglion cells of our eyes, there's a dye called melanopsin, which is very sensitive to blue light. And when those cells are stimulated, they stimulate the suprachiasmatic nucleus. So they turn the SCN on. And so during the day, your light helps to keep your suprachiasmatic nucleus active. When sunset happens and that light gets removed and your SCN is winding down anyway, it then becomes very quiet and your melatonin gets secreted. So it's a very elegant system, but there are quite a lot of things that can go wrong in there. And circadian rhythm disorders happen when the internal biological clock becomes desynchronized with the outside world. Either it just gets shifted earlier or later, so an advanced sleep phase syndrome where people fall asleep early and wake up early, or more commonly a delayed sleep phase syndrome, which is your typical teenager who falls asleep at 3 in the morning and would sleep through to lunchtime if their parents let them. You can get a free-running circadian rhythm disorder where there's no synchronization with the outside world and that just rotates around the clock. And who's likely to have that? Sorry? So shift workers do have a circadian rhythm disorder called shift work sleep disorder quite commonly. But this free running disorder is specific to a particular group of patients, which are patients who are blind, who have retinal blindness and therefore aren't able to perceive the light to synchronize it. Some people just have no discernible rhythm, and you've all probably had a circadian rhythm disorder at some point in your lives when you've gotten on an aeroplane and taken your body clock and dumped it in a different time zone, and your body clock is now out of sync with the outside world. How do we assess them? Well, once again, generally this is a diagnosis made on history. However, it's really useful to have a sleep diary, and this is true of almost any sleep disorder, because very often if you ask a patient, tell me about a typical night's sleep, they will do one of two things. They'll either tell you about last night, whether last night was typical or not, or they'll tell you about their worst night. And having a sleep diary gives you nice longitudinal data. And if you suspect a circadian rhythm disorder, a good way of doing the sleep diary is not to get them to fill it in, fell asleep at 10 o'clock, woke up at 7, but to give them a grid, something you do, for example, on an Excel spreadsheet, and you get them to color in the blocks where they're asleep. Because what you get is something like this. You get a visual representation of what's happening with their sleep. So this is someone with a free running disorder. The blue areas are the areas where he was asleep, the yellow when he was awake. And what you can see, you can just eyeball it, and it's very apparent straight away. The time of sleep onset is progressively delayed. He's sleeping later and later during the day. Very clear pattern. And you won't pick that up as easily if you're looking at actual numbers on a page. We can assess circadian rhythm disorders using melatonin assays, but actually it's very rarely done in clinical practice. It's more of a research tool. The only kind of objective thing that we will sometimes do is actigraphy. That's an actigraph in my hairy arm. It's basically a little wristwatch with a motion sensor, very much like you have in your smartphone. It just measures movement. And we can then use an algorithm to determine is the person awake or asleep. And the beauty of this is that you can get very nice longitudinal data in the real world. It's very unobtrusive. And here's that same patient and their actigraphy. And in this one, the white areas are the areas where there's no movement, and therefore when they're asleep. The black areas are areas of activity and therefore awake. And you can see, once again, very clearly, a nice sort of progressive delay of their sleep period. So this is useful for confirmation. I do it primarily if there are occupational issues or if there are funding issues in terms of getting a person a light box or getting someone who's under 55 circadian or whatever. But to be honest, your diagnosis is generally made long before you give them the actigraph. So how do we treat it? Well, essentially, we've got two avenues to affect that suprachiasmatic nucleus. We can turn it off using melatonin, or we can switch it on using light. And this is what we call a phase response curve. So this over here is the person's current sleep time. This is when they're falling asleep and when they're waking up. And generally, they'll secrete their own melatonin about 2 hours before their sleep onset. So you can use sleep onset as a proxy measure for when they are secreting their own melatonin. The red line tells you what you will do if you give melatonin at any point during the day. If you give it somewhere there, you will phase advance them. You'll move their body clock forward. Give them melatonin over there, and you will phase delay them. You'll move their body clock later. Similarly, the blue line is what would happen if you gave them light, and in particular blue light or daylight. Give it to them there, and you will delay their sleep and their body clock. Give it to them there, and you will advance it. So we can use these two interventions in tandem. And if you have someone, for example, with a delayed sleep phase syndrome, they're falling asleep late, waking up late, you want to phase advance them. So what you do is give them melatonin over there, and what I tell my patients to do is to take their melatonin 6 hours earlier than the time that they fell asleep the night before. And that will pretty much put them at the peak of that curve. And then we ask them to expose themselves either to daylight or to a SAD lamp immediately on waking in the morning. If you wait an hour or two, you've missed the boat. So it's got to be immediately on waking up. And it can be a very effective way of stabilizing and manipulating their circadian rhythm. So, in conclusion, hopefully what I've demonstrated today is that most organic sleep disorders are actually diagnosed on history. You don't necessarily need to have a polysomnogram to diagnose these disorders. But having said that, although sleep studies are very often only for confirmation, you can't really do sleep medicine without them, because there are some disorders, such as the periodic limb movements or REM behavior disorder, where you need that polysomnographic data. And although these are organic disorders, and there are lots of medical treatments for them, there are also a lot of non-medical treatments and behavioral and psychological interventions that one can use. And that's it. Thank you very much. Any questions?
I'm interested in the relationship between seasonal affective disorder and circadian rhythm disorders. I use quite a lot of light therapy, and what patients often describe to me is a shift sometimes in their sleepiness, and it seems to deal quite well with the daytime drowsiness that a lot of people describe. Is there a relation?
We think there probably is, but it's slightly complicated. There's been a lot of work done in Oregon by a guy called Alfred Louis, who's done a lot of research on the role of melatonin and light in seasonal affective disorders. And what he thinks is going on is that actually your circadian rhythm is delayed. You have, in a sense, a delayed sleep phase syndrome, but your sleep remains in the normal period of time. So in other words, your sleep doesn't shift. Now, our metabolic nadir, the minimum period of our alertness, our body temperature, our activity, is at around 5 in the morning, and we normally sleep through that. If our sleep stays in the same period and our body clock is delayed, what might then be happening is that when we might be waking up when we're at that minimum, when our body is actually really wanting to be asleep. And that's what leads to this kind of awful fatigue in the morning, the lack of energy. And when you then use the light, what you're simply doing is shifting the circadian rhythm back into sync with the sleep. And his research shows that probably 75% of patients with seasonal affective disorder have a delayed circadian rhythm. So, yeah.
How about the circadian rhythm changes in dementia patients?
With dementia patients. Yeah, this is what we know is that the circadian rhythm is significantly disrupted in dementia, and melatonin levels are very low. And so we were very hopeful that actually if we gave melatonin and used light therapy, it would help to restabilize the circadian rhythm, and actually, unfortunately, results have been relatively disappointing. There are a few patients who will respond, and the truth is that melatonin and light are such innocuous treatments that they're probably always worth a try. But the evidence is actually that in dementia, they just don't seem to work that well. What does seem to work best in those patients is increasing levels of physical activity during the day. And they've looked at all sorts of interventions to correct sleep disorders in dementia. None of them have really been massively impressive. And I think the conclusion that we've come to is that actually, in the same way as anybody else, patients with dementia, their sleep disorders are going to be multifactorial. There are going to be lots of different factors, and different patients will be sleeping badly for different reasons. And therefore, you need to take a very holistic approach. You need to try and stabilize the circadian rhythm. You need to give daytime activity. You need to help them avoid napping during the day, involve them in relaxing activities in the evening, and really sort of create a very holistic program so that whatever the primary cause of each individual sleep disorder, you've got at least some chance of catching that. Seth?
I noticed, Hugh, that you didn't mention the hypnotics. Is there any place for their use in sleep medicine?
Yes, absolutely. So I haven't talked today at all about the most common sleep disorder, which is insomnia, and largely because the remit was about organic sleep disorders, and I think insomnia is very much a psychological sleep disorder. But yes, there certainly is, and there are some patients whose lives are better with hypnotics than without. And we do sometimes use them in these disorders, so where you can't get on top of restless legs, sometimes what you can do at least is just knock the patient out with a hypnotic, so that, yes, they have discomfort at night, but at least they get some sleep. The same is true with periodic limb movements. And once again, in some of the parasomnias will respond well to hypnotics. Some will be exacerbated, so there are lots of people who sleepwalk on the Z drugs, but there are some sleepwalkers who stop sleepwalking when you give them Z drugs. Once again, there's a huge lack of evidence here, unfortunately, so to a large extent it's very much trial and error. Okay. Should we just take one more, because I'm aware I've gone over time. Yeah.
So just going back to dementia, is it maybe it doesn't work because you have picked the moderate to severe dementia as opposed to very mild early dementia? Do you think it should be more useful in memory clinics?
It may well be. It's much easier to do studies in care homes, and that's why you're probably working with the more moderate to severe end. It certainly would be worth doing in those who are still living at home, because the single biggest factor that leads to nursing home admission in dementia is disturbed sleep at night. The family can cope with most things, but once you get the patient wandering around at night, turning on the cooker at night, wandering out the front door at night, that's the point at which the family feel they need to then go into a care home. So I think it's an area that needs to be looked into. That's clearly ripe for some research. Okay. Thank you.